Hello. Good. We are all getting ready for an amazing session. And I want to welcome all of us to the London Global Cancer Week Radiotherapy Spotlight session and panel discussion today. We welcome our in-person audience and also our virtual audience. Thank you for making time to be here. My name is Dr. Kofi Adesiche from Ghana, and I'm a radiation therapist and an ambassador for the Global Coalition for Radiotherapy. I have worked in the radiation therapy environment for close to 20 years. I look very young, and currently heading the department for training and within the University of Ghana. Today we want to welcome an audience from around the world, which truly highlights the value the Global Coalition for Radiotherapy community and the radiotherapy nationwide, worldwide as a whole. It is essential for us to strive to deliver safe, quality, and accessible radiotherapy all over the world. With an increasing number of patients with cancer and global economic challenges, it is essential, again, we improve productive time to ensure sustainable services and better outcomes for all our patients. For me, coming from Africa, I see a great need for this because all over Africa we are struggling with machines, equipment, and even access to treatment. Patients are paying out of pocket, and if you are diagnosed and you don't have money, then that will be a hell. So this is a great day for me today, and I want to introduce someone special who will be our moderator for this session. In fact, I've been following her for some years now, and I look at the passion that she drives and carries along, and it amazes me what it will be for us to get someone like her in Africa. But she's doing amazing for the world. And I think some few months I heard her talk about some equipment, new equipment that United Kingdom will be receiving. And I was just there and asking myself, when you get all this money and you get these machines, bring your old machines to Africa. Professor Pat Price is a radiation oncologist and a clinical oncologist who has worked for more than 30 years. You know, the passion with which she works is amazing. Today, it is a pleasure for me to introduce her to be our moderator for this session. She is an advocate like no other, and we are pleased to have her chair the Radiotherapy UK and also a co-founder of the Global Coalition for Radiotherapy. I want to welcome the moderator, Professor Pat Price. Thank you so much.
Kofi, thank you. And you should not have said all that about me. It's not about me, but thank you. And it's really, you know, I was thinking here today, it's easy to be an advocate of radiotherapy, great technology, fantastic patients, but also what a community. You know, we talk the same language, it's all geeky stuff, it's multidisciplinary, industry, clinicians, radiographers, physicists, and then to expand it now globally and to meet yourself and all the fantastic, you know. And also, it's really good, London Global Cancer Week. Now, radiotherapy being a really integral part of that is key, because as we've had, like the meeting we had yesterday, in lower and middle income countries, if you've got so little, 38 countries still have no radiotherapy. If you have so little, where do you start? You actually have to start with radiotherapy. Countries that don't even have morphine, you know, there is a huge need out there. So honestly, it's a privilege to be involved with all you people. So fantastic, and great. We've got this session today, and thanks, Darren and everybody from the Global Coalition for sorting this out, and also Radiotherapy UK support. So really, what we want to do is to have a really good discussion here and about where we're going to go. We're talking about improving productivity and quality of radiotherapy services, and that's key because we want it to be sustainable, and ultimately we want better outcomes for patients. But there's obviously huge challenges in delivering high standards of performance, and it requires so much integration of various strategies and technologies and politics and local and everything really. So we've broken down this session into 3 sessions. First is going to talk about access, clinical service and patient flow, and we've got Claire, Lawrence, Vishal and Solomon talking there. Then we're going to talk value-based funding and evaluation, really important. If we can show the value and the economic estimate and the evaluation, that's how we move forward. And Sophie, Rob, Kate and Habib are going to talk about that. And then we're talking about implementing quality of radiotherapy, which is, again, vitally important. And Frederick, Lisa and Amaka will talk to us about this. So each speaker, it's going to be a race time here now, each speaker will present on their own topic and how that drives productive and quality of radiotherapy, and then I'll ask some follow-up questions. So please look at the agenda, and there's a QR code. We've got a full bio of all the speakers, so think of some questions yourself and how we can engage. And then I'll ask a few questions, and then at the end we'll have a good half an hour, so really save up. If you've got burning one, shout it out then, but otherwise let's get going on that. Now, you've got 4 minutes each. That's it. Out of there if you go on longer. And then a follow-up question. So I'll be strict, otherwise we're not going to get through it, because we really want to get on to our discussion at the end. So without any more ado, so first of all, we have Claire Smith from ICON, and we're going to hear from her about workflow organisation and implementing the stream flow of workforce. So welcome. Crack on.
Good morning, everybody. Thank you very much for inviting me. I feel very privileged to be here and to speak about a topic that is, I think, incredibly important, yet maybe under-referenced in what we do. So it's how do we do what we do every day, and how do we do it well? How do we make sure that a patient is moving through a workflow or a care path in an appropriate way, and managing those things well can actually result in quite significant outcomes that maybe can support some of the other things that we're talking about here around access to linear accelerators and those sort of things. So what is workflow optimization? It's probably words that if you enter a radiotherapy centre, people feel a bit nervous about it. We're not talking about asking people to do things in a faster way. We're not talking about people doing more with less. We're talking about understanding what are we asking our staff in our centres to deliver every day, and then what does that mean for the patients who are going through that pathway. In radiotherapy, we've got sort of 3 or 4 or even 5 different staff groups who need to participate in that pathway. And as we've assessed our pathways at ICON, and also I've done this work with a lot of other providers, working out why does it take this much time for a patient to move through a pathway. So is 28 days the right number? Is 10 days the right number? And I think we need to flip it around and sort of understand how long do things take. So a good example of this is when we measured within our own network, how long does it take for a plan to be produced? And the average across all of our centres, this was 40 centres, was 9 hours. When we sat people down and said, do a plan, the average was about 180 minutes. So what we know is that people aren't doing things slowly. They're not doing things in a bad way. What we realised was that those people were doing too many things at once. So instead of asking them to do 3 plans at once and go over to simulation and do this and that, what we're trying to manage is the task that they're doing and when they're doing them. We also discovered very quickly, and I'm sure many of the people in this room have seen this, is if we have a care path of 10 days, about 8 days in that care path are spent where that actual workflow is doing nothing. So what we did is we assessed the whole pathway. We understood how long everything took as average times. We didn't ask anybody to do things more quickly. We didn't ask people to do overtime. And then we went and placed the tasks with the right person at the right time. So that takes a lot of engagement with our doctors. Now, I'm not going to point out the doctors in the room, but some people might say that a lot of the time is spent waiting for the doctor to do their task. However, we said, well, why is that? Because the task was available for the doctor when the doctor wasn't ready to do the task. So what you need to understand is, when is the doctor available? When does their task need to be done? And make sure that it's ready for them. And actually, just by implementing these small changes, we could take timelines with respect to how long a patient took to go through from consultation to start of radiotherapy from more than 10 days, immediately down to 5 days. And in our China business, they're very, 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 very passionate about these fast turnaround times. And actually, almost all of their patients go from simulation to patient start treatment in 24 hours. And actually, all of those patients are also modulated. So including physics QA, all of the quality metrics that we apply in our other businesses internationally. So the driver for that is actually doctors and patients, lots of travel, lots of wait lists. So I think the key points here are not about saying to our staff, do things faster. It's actually about us, leaders, managers, understanding what we're asking them to do, placing them in a position to do it well, taking the pressure from the end of that care flow. What we also found is errors tend to happen at the end. We've got 10 days to do the job. 90% of it gets done in the last 24 hours, sometimes when the patient has arrived. So we removed those pressures and put them at the start. So pinned everything to when the plan was due, 3 days after the simulation, rather than say, let's make the plan due on the day before the patient starts treatment. So as we've done this, what we've seen is a much clearer representation for our business of how much work are we asking our staff to do, and if we can see that that work is starting to peak up, then we can actually manage it for them. Not say, you're on your own, manage it, do overtime, because overtime is not the answer. Making sure that our staff feel like they can provide the quality care, but also go home at the end of the day and feel satisfied that they've left and they know that everything's taken care of. And then also be able to really adequately track what our workforce needs. Still good? So the key points here are doing things in the same way. It's not saying that everybody has to produce in a plan the same way, but they need to produce a set of quality metrics in the same way. We need to be tracking that time that it takes to do things, making sure that our training aligns with what we're asking people to do, and also auditing the program along the way, and making sure that when we see these things start to change or elongate, we go and ask the teams what's going on. Again, most of the time it's a training issue and staff just need some additional support, and then their workflows and timelines come back into what we'd expect to see across our network. So what you can achieve by doing this, get your patients onto treatment faster. That automatically reduces the wait time. Every country has different objectives and metrics around that. In the UK, it's sort of 62 days. That's a long time. If we can take that time and through the radiotherapy pathway shave 10 days off it, we're going to do a lot of positive things for the patients and also a lot of positive things for the staff.
Great, no, thank you so much. So Claire, thank you. Just one question. So yeah, I think you've covered the business about you're not going to burn staff out. You've obviously, it sounds to be as though it's communication, it's about thinking it through, and also probably having a desire. If the Chinese can get it done in 24 hours.
That's right.
My phone, yeah. Yeah, so if it can be done. So I suppose we've only got time for one question from me. Probably she's glad. How would we benchmark? How would we say what is the productivity we're aiming for? I think if we went from our current UK to 24 hours, we'd have a heart attack. But how do you handle that?
There's probably 3 measures. You have to measure the time that it takes. You have to understand what the time should be in your particular centre. So you need to be tracking that weekly with respect to how long the patient pathway takes. You also need to be tracking patient satisfaction. It's a really, really important one.
Yeah.
So, net promoter scores from patients and get their feedback. And what we know in our business is when patients have to wait, that upsets them. In a lot of our countries, they're also travelling a long way. So when you can bring everything closer, you can keep them away from their family for a less amount of time as well. And then you also need to, very importantly, be engaged with your staff and hear their feedback, and to be able to track their satisfaction with what they're doing in every day. And one thing that's really important that what we've done is actually make it visible. Everybody can see everybody else's workload and everybody else's centre in our business. So, and it's not because we're trying to measure people against each other, we're saying we need help, yeah, and then we start to share that workload across different groups.
And that's kind of modern practice, isn't it, in other business? Fantastic, great insight, fantastic work you've done. Oh gosh, that's the lesson for us all, isn't it? 24 hours. Right, okay, Lawrence, he wasn't sitting up here. Now he's, yes. Lawrence is going to talk to us from the MD Anderson, and he's going to talk to us about automation of planning, lots of lovely AI. So give us some hints.
Yes, good morning, everybody. Next. It's a test. Why should you be allowed just to sit here? So what you can see here is an upper abdomen CT scan. One was contoured manually, which is a sort of traditional process where we go and we draw around everything so that we can assign dose constraints to the different structures. One was done automatically. So, and the QR code takes you to the link for the paper if you're interested. So while you're thinking about that, let me give you the background. So you know, everybody's, you know, if you watch the news at all, you know that AI is here, ChatGPT is everywhere. In radiation oncology too, ChatGPT too, but also different forms of AI really coming to make differences to our workflow. And so this is the example for the contouring process, of course, when you have, after you've had your CT scan for radiation therapy, you know, one of the first things that happens is that you do the contouring, you delineate everything that you don't want to treat and also the things you do want to treat, and then you move on to the planning process. And so AI is here, basically. This is something that's going to make massive differences to our workflow. It already is. It's going to make differences in terms of quality, in terms of consistency, because you can imagine, I mean, look, this is pretty complex thing to do. If you're doing something in the head and neck, it's even more complex. You can imagine that if I contour something or if my colleague contours something, you're going to get different answers. It's inevitable if you do this stuff manually. AI is really going to change that. Also efficiency. So we've put a lot of these tools into our own clinic. This particular tool is used for around 50 patients a month. And the radiation, in our practice, it's the radiation oncologists who draw these structures for this particular service. And they tell me it saves them 30 to 45 minutes per patient. So that's per patient. So that's a massive time saving over all of the patients that we treat. And then also, what do I got? I've got consistency, I've got efficiency, and quality. So those three things are going to be massively changed. Okay, so which is which? Point in a certain direction. Computer is left? Because it's better? Yes. That's not the point I'm trying to make. Left, we've got mostly lefts and a lot of undecideds maybe. So you happen to be right. But the point, I mean, my point is that they're basically the same, right? You can see some differences. They're not clinically meaningful, most likely. They're basically the same. So the computer has given us something that is basically the same as what you can get by hand. And in our practice, so we're about 350 to 400 patients per month contoured with these types of tools in our own practice. Okay. The test never ends. So, of course, once you've done the contouring, the next thing you need to do is the planning. And so what you can see, this is a head and neck plan. The shaded area is the target. One of these was generated in our sort of, I guess, traditional way of somebody with lots of button clicks and trying to, and sort of massaging of the plan to get a good plan. One of these is fully automated. Which is which? You can't tell. No one's even, everyone's too scared. There's no prize, by the way. Okay, so it's the one on the right. This one is better, you're right. So, yeah. so the one on the left, it was actually the original clinical plan that was used to treat the patient. The one on the right was generated with no human interaction. You know, they're basically the same. The one on the right, there's a little bit less spread of the dose into the sort of surrounding structures. So when we showed the oncologist these, they had a sort of a small preference for the one on the right, but really both would have been okay. And so this is the point. So once you've got these things out there, you've got consistency. You know, all the plans, they're very consistent. They all look the same. They have 1 second left. Consistency, quality, efficiency, and really this can be very low cost because it can be made available once you've developed the tools. There's no real cost involved. So that's it. It's going to change all our lives.
Perfect.
Yes.
We love it. We love it. I love the way he had his timer on there. Very impressed. Very impressed.
Physicist.
Oh, right. So thank you for coming all this way. Okay, so why aren't we just getting on with it? Why are we, why are we slow to adopt here? What's the barriers here? Aren't we doing this?
Yeah.
Then we can get our things done in 24 hours?
Well, we are getting on with it, I would say. So the contouring, there's vendor solutions out there. There's lots of solutions.
We're just not buying them, is that right?
Well, the barriers are cost is one of the barriers where what the vendors are charging. Infrastructure is another barrier, and then there's concerns about risk. So you know, when you put these tools into your clinic, you need to think about the risk that's involved. It's not risk-free, it's radiation therapy. So you have to really consider that, but it can all be mitigated. I would say within 5 years, we'll be doing this for everybody.
That is absolutely fantastic. And so if we're going to be doing that, does that lead more to centralised planning? Or do you need both ultimately for the ultimate solution?
Yeah, I would say you need both. So there's definitely going to be more, I don't know if you call it centralized, but sort of web-based or cloud-based type planning. There's a lot of advantages to that because it gives us consistency. And imagine if I'm the patient and I go to a center in London or a center in Texas or Africa and I get the same treatment. How cool would that be? You know, certainly. Or even the hospital next door, we don't even get the same treatment right now. So centralized planning, I think, is really important. But there's the treatment planners and everybody, there's still going to be cases where you need people to sort of focus on.
Absolutely.
It's not sort of, lots of patients, it's a sort of a factory line case where you can treat them in a very consistent way, but there's a lot of sort of what you might say niche cases as well. So
we need to be making the case for the funding on consistency. And also, to be honest, I think tried to make the case here is that if I could save like myself 2 hours doing a plan and it was going to be something like 40 quid to actually get that planning for the patient, that's £20 an hour. You know, I'm a cheap date. You know, this is actually pretty good here.
Well, it really gives you the opportunity. I think we'll be able to scale our efforts. So, and we're putting these tools into clinics in South Africa right now, and it's really people are very excited because you can potentially treat more patients with the same team that you have right now.
And also then have remote sort of supervision if needed as well.
Yeah, potentially. Yeah.
Great. Come on, we need to think positive. I'm sorry if I jump up and put people off. I don't mean to do it. But, right, okay. So Vishal is now going to talk to us from Varian, speaking about resource management. So fire away, and I'll try not to be so intrusive that I jump up. Yes.
Morning, everyone. My name is Vishal Borikar. As you can see, I'm looking after service marketing, EMEA, at Varian. I'm going to talk about the resource management and how it impacts the productivity on the RT treatment. I have kind of broadened it a bit and said, it's not just resource, but also a maintenance management. So that's the topic I'm covering. Can go to the next slide. Just go to the next slide. Just one slide, actually. And one more. Yeah, so that's the one I have, and basically, if you look at when you think about the maintenance, the word that usually comes to your mind is the uptime or the downtime. Is the two sides of the same coin. But that's the number that usually comes to your mind. And when you realize that this is not a kind of, it's outcome, right? There are many reasons which causes the improvement or improvement in the uptime. And this is what I've tried to highlight here in this slide. There are many causes for the improvement in the uptime, and I think a lot of these things are not new to you, but I'll try to bring in some of the practical things that might be aha moment. So, the first point I'm trying to mention here is the basic infrastructure and the stakeholder support. Our machines, if you look at them and compare that to the past, they have all improved in many aspects like security, reliability, sustainability, all these aspects, and even accuracy of the treatment, the most important one. They have all improved in this aspect. But that does not mean that they can do without the basic infra, right? Electricity, for example, cooling, those kind of aspects need to be taken care of by the stakeholders, and there could be many forms of stakeholders, so I'm not putting any name here. But one of the things that came when I was talking with different people, and through my experience, what came out is a lot of times we don't put a maintenance budget. A lot of times what we do is we buy a machine and assume that the machine would maintain itself, which is an absurd assumption to do, right? And that's the important part, which I think I would like to definitely highlight, and have a dedicated maintenance budget. So that was my first part. In terms of second part, I'm trying to highlight the spare parts and the supply chain issue. The usual thing what we say is, we need to have a spare parts facility next to the clinic, which is practically impossible, right? With the number of and the scale of radiotherapy today, it's impossible. So there, I think we need a better and the improved decision in terms of what is our strategy, supply chain. But one point that comes out on this aspect is the importing and the custom process and the guidelines. In many countries, still not clear when we import the parts for the medical equipments, what is the guideline, what is the overall guidance in importing that, and that causes a lot of delays, even when the machine is down. The third aspect is the human resource challenge. With technology now, we have all the possibilities to look at the training, not just in person, virtually, or also hybrid possibility of training the people. But obviously, the better thing is obviously to have someone next to the machine, trained, highly skilled, who can maintain the machine. But again, that is practically impossible today, right, because of the scale. So there, I think we need some kind of strategy in terms of how do we make sure that there is sustainability in that aspect, especially in some parts of the world. And the last one is the connectivity. I think we are able to connect to our machines 24/7. We can diagnose them remotely. We can even solve some of the issues remotely. But the main important point there is the connectivity. And if you realize that in some cases, connectivity comes at a time when you install the LINAC, you can imagine what is the big hurdle there. So those were the main points I wanted to highlight. Hopefully, I'm in the time zone.
Well, I think that's the prize figure. Look, that was really interesting. It's lovely to meet you in person. So what it's during London Global Cancer Week, we've talked a lot about this and about how not just in lower and middle income countries, but then also in conflict and areas about its big infrastructure, getting it all together. Now, do you think we should be making more in our bids to governments and local people about how, if you get your radiotherapy right, you get a lot of things right. You get your infrastructure, you get your transport, because it's not just health. It's in countries, it's everywhere. Yeah. What do you think? Because I also was conscious as well, because the very good work you did in Ukraine with knowledge of remote access to machines, you knew what was going on in those centres when they were having a bad time early on. Yeah. So where's the priority there?
In terms of, I think, overall, if you look at if you want to highlight one or two areas, what I would say is really having a kind of, training to the right people, having that overall sustainability. It's not always going to be always possible to have one person sitting next to a clinic or a machine. So having that sustainable strategy in terms of, how you're going to handle that challenge of trained resources. Yes. I think that is going to make a major difference. And other points I mentioned is really the spare parts. Yes, even when you have, let's say, a local strategy, how you have a local center available in that region, there is going to be some time delays, right? But if you make sure that the cost, the import processes of importing things inside that region is easier and not heavier on the clinics or the industrial sector, then it would definitely help.
And that's really important to prioritise. I heard something awful yesterday. There was some machine that was down, and it's near Garth, somewhere around. They were just waiting for one spare part that was being held up. You know, so we need to be saying this. Health is important, cancer is important, radiotherapy is important, and all these things. Thank you. That was fantastic. Thank you ever so much. Right, great. Now we've got Solomon again. So Solomon is coming to talk to us from the Uganda Cancer Institute, and he's going to talk to us about enhanced accessibility. So thank you, Solomon.
Thank you very much. Next slide. So access to radiotherapy, as we well know, remains extremely low globally. You might be very familiar with this map. It shows the number of radiotherapy machines per million people. We know that radiotherapy is a very essential, plays a very essential role in cancer treatment. In this, we know that up to 60% of cancer patients will need radiation at some point during their care, and we know that in up to 40% who get cured, radiotherapy plays a key role. And when we use it in palliation, over 70% patients get very excellent control or palliation of their symptoms. However, despite all this knowledge, the access and utilization rates remain extremely low in different parts of the world. And the key barriers are mostly awareness and funding. Next slide. So just to understand where the problems are, in areas where there's a machine, for instance, where I come from in Uganda, then you find other barriers which can be at the patient level, within the healthcare system, or even amongst providers and within equipment. It's difficult to know which of these is the most critical barrier, but we think about them. In terms of the patient, it's factors such as the age, the income, cultural beliefs, as well as literacy levels. In terms of the providers, it's more of awareness. Many primary care providers might not be aware of specific indications for radiation, and this will delay referral of patients to get the right treatment. And in terms of the entire system, it's waiting time, as mentioned before, which might be due to congestion, due to poor access, due to long distance to radiotherapy facilities, as well as the huge queues to access treatment. What can be done to improve? There are several things which can be done. I think, thinking about this, I think leadership plays a key role, as well as partnerships with people who have done it, and establishing sustainable funding mechanisms to ensure continuity to overcome these barriers. Thank you very much.
I think that was beautifully done. I think those slides are really helpful for us all there, because I'm not entirely sure that isn't the same in our country. So this is great. So I was thinking, in terms of, we talked yesterday, there was a round table and talking about who should fund radiotherapy, and Kofi was saying in Africa it used to be right, the people should fund it, and then there was the thinking, oh, it should be some world global cancer fund, but it really got back to the governments should fund. They need to take responsibility for their patients and then fund it that way. So how do you, this is a beautiful summary of it, and how do you communicate that to national funders to say, it's a bit complicated? Because I think a lot of them find radiotherapy a bit complicated anyway, but then actually there's all these other things as well. So how have you had success in terms of communicating all that?
Thank you very much. Communication is very key towards overcoming these barriers, but I think establishing a national cancer control plans is the stepping stone to be able to mobilize funds. Because whenever you want funds, then the question is, what is the plan?
Great, yeah,
And what's the commitment? So having national cancer control plans is a very important step.
So as the radiotherapy community, we should be supporting national control plans as well. It is our business now. Solomon, thank you for sharing your expertise.
Thank you very much.
So if Wes and the UK government are listening, national cancer control plans, please. Right, okay, right, that was great. So now we're getting on to our next session on value-based funding and evaluation. So this is really important. So Sophie Ward, lovely to have you on, from Hammersmith UK. She's going to talk us about collaboration between public and private. Fantastic, thank you.
Do I press here? Yeah. So thank you for having me today. The challenge of this, the topic, was to talk about the collaboration between public and private from a marketing perspective. Often this topic is discussed on a more operational or commercial way, so the session is, what I've prepared is going around marketing. So the slide is not as nice as yours, I'm afraid. If going for marketing is a bit odd, but the idea when we engage in marketing communication around healthcare is to follow your patient, really. So that's the focus for the team at Amethyst, is to, this idea of patient-centric is not just a buzz marketing word, is actually the reality of what we do. In fact, any new member of the team, when they start in the department, the first thing that I ask them, the only induction they get, is to first answer the phone to the patient, because that gives us really the insight that we need to then provide the information, the communication, the support, and we know that's what a long journey for our patients often is once they receive the diagnosis of cancer. So with that, we advocate transparency of pricing structure when we communicate with patients. We seek a partnership with the healthcare providers we work with, and that obviously ranges from PMIs, they are important actors, so that's private medical insurers, government entities, and that obviously includes the environment we work in, because the strategy of the communication is obviously involved in the ethical practice of engaging with the patient whilst communicating the right support during their journey. We feel that, I'm getting a bit lost. We feel that by approaching the communication strategy, it provides the patient the tools that they need to perhaps be more in charge of the decision they're making. And I know that seems quite disproportionate, because often they are so overwhelmed and emotionally it's very challenging. So this idea of empowering the patient through the journey for the decision making in their care plan is something that is very meaningful, means a lot at Amethyst. So I'm going to the next slide. In terms of actual marketing, what that really means for the strategy, I've included here a few words that perhaps are not typically associated with healthcare, but we have certainly noticed a massive change post-COVID. And we will talk about digitalization of healthcare, tech, and AI as well. That means for us, coming from perhaps a more traditional background, marketing background, and I include myself, we utilize techniques such as omni-channel marketing, and those are models where we integrate completely CRM platforms, direct marketing platform, social media. We know that big giants such as Amazon have developed healthcare channels. YouTube channel has developed as well their own healthcare channel, and so on. So we feel that by consolidating all of those different medium, we can have a better reach, and we differentiate B2B channels for our medical community to B2C, the patient. And I go back again to this idea of empowering the patient by choosing the right language as well, because we find that by having this patient-centric approach, sometimes the language that the industry would use is not quite in match with what the patient understands. And again, if I expand with the family, because we know we don't treat the patient, we have to allow the family to be involved during those communications, those conversations. The language has to be simplified. And so that's an area we worked very hard with our doctors as well, engaging them on that level. Thank you.
So that was brilliant. So what I got from that also, there are lots of lessons from industry to actually transfer to public sector as well, aren't we? So we don't do this very well. And beautiful about how you were talking about all the techniques you have in the private sector, transferring that to patient empowerment as well. I had a very good talk last night. They said we mustn't call it patient-centric. That's like the bull in the bull ring. It's patient-led. But I think, and do you think, how do we move forward with this? How do we make sure that we learn all these lessons and transfer it to improve patient care in the end?
Yes, I actually quite like the idea of patient-centric because, again, because of my background, I come from a very strong e-commerce background. And I think if we stick with the patient, and again, the long journey, we can't go wrong. And that means we should also be thinking about holistic care, all the elements we can add to the support the patient can receive. We can do that digitally because healthcare is becoming digital. We can also eliminate discrepancies between regions, and by utilizing the digital elements, we can have a fantastic reach, really.
And it makes it clear your point about asking the patient as well, what they refer to. Big topic. Thank you very much, Sophie. That was really, really helpful. Thank you. So now we have Bob Yates from the Centre of Universal Healthcare. Bob here? Yeah, that's hiding at the back. Yes, and I was been referring to our meeting yesterday a lot of the time. Sorry, that was... well,
thank you very much indeed. And just to say, actually, I've just moved to the LSE as of this week, actually, so I've got a new home. But yes, thank you very much, Pat. And in fact, I will be sort of summarising, I think, some of the points we made at yesterday's meeting. So I just very briefly want to talk about funding, financing. How should radiotherapy services be financed, and some tactics maybe as to where we get the money. And really to suggest that the best approach is to frame this within this great debate about universal health coverage. It's driving the global health agenda right across the piece. And what is universal health coverage? It's very, very straightforward. Everybody gets all the health services they need with financial protection. Everyone sort of gets this, in particular politicians get it and like it, which is very important. Now, the very important point that Pat's referred to is that you can only reach universal health coverage through predominantly public financing. There were these awful sort of experiments about 30 years ago, sort of trying to push the financing burden onto households, particularly in developing countries, by the likes of the IMF and the World Bank. But clearly, if you're going to have this universal system that everyone gets the services, you need healthy, wealthy people cross-subsidising the sick and the poor. Now, how does this sort of relate to radiotherapy? Well, going back to that definition, well, clearly people requiring radiotherapy services are very high-need groups of people, whose lives are often threatened. So, and also because the services are often out of pocket will be very unaffordable, they must be publicly financed. So there is a very good case also with the fact that radiotherapy services, many of them are very, very cost effective, that they should be in that benefit package for universal coverage. And of course, the important thing is to make sure that they get in there and the tactics that we might employ to make sure that's the case. And there are many middle-income countries getting to that income level now that this is a reality. So bottom line is radiotherapy services should be predominantly publicly financed. I would also say that domestically financed as well. One might like to think in an ideal world that, the West would sort of fund all these services in developing countries. But sadly, the realpolitik of the world at the moment, and given our performance in the last pandemic, that's not going to happen. And so I think sort of ideas of, say, a global fund for radiotherapy for the birds, it's just not going to happen, I'm afraid. So Then how do you make sure that it gets in the benefit package? And just some sort of suggestions for tactics here. Of course, you need evidence and research. And, you know, what an amazing group here discussing this. You know, we have lots of very, very, very strong evidence and research. We need more of that, but we need to get it to the policymakers in a form that they understand and they like. So perhaps we need to sort of go beyond just thinking of the journals and thinking of the tactics that we get this onto Wes Streeting's desk and the equivalents across the world. I think another important thing is to think about an indicator or indicators of service coverage that people that get into the news, that people see it's going up or down. It's difficult to do this, but you know, one thinks, say in the UK, there's a big fixation on waiting times in hospitals. You know, that's got into the public discourse. Perhaps one needs something similar for radiotherapy coverage. To state the blinding and the obvious, you've got to get political. You know, there's no point sort of ignoring the fact it's competition. I'd say do it within the UHC movement. That, you know, we're united. We stand in presenting this to ministries of finance. But you have to get political. And therefore, one gets involved in things like fighting injustices and inequities, using the media, you know, naming and shaming countries that are underperforming, all the sort of the dark arts of the politics, really. And of course, make sure it gets into the global debates. And I think, you know, the awareness day is a fantastic idea, you know, sort of that of all these ways to sort of get it up the agenda, World Health Assembly, UNGA, you name it, is a very smart thing to do. And in doing all this, really be thinking about the political marketing of this. How do you sell this to the key strategic policy makers? So it's all about selling the benefits, really. Obviously, the health benefits to the Minister of Health and the population, the economic benefits of all this to the Ministers of Finance who control the budgets. But I think the ones we often miss are the sort of societal and political benefits, you know, to really sort of go route one to the politicians who, at the end of the day, what they want is power, to stay in power, and sort of sell this idea to them that if you do right by radiotherapy services, there are votes in this will make you popular, and then you get their attention. Thank you. Thank you.
So, question to you. Completely agree with all that. Universal health quality now, universal health now. How do we make sure that's not lowest common denominator, especially in radiotherapy, where you can have excellent radiotherapy and you can have basics? And is that the use of like the private sector in, as we talked yesterday, have public-private partnerships for delivering it, not necessarily funding it? Mm-hmm. So is that a mechanism? My worry is, you know, a bit in the UK, a minimum standard in the NHS. Okay, if you have a heart attack, we will treat you, but quite frankly, if you need your hip replaced, forget it. Mm-hmm. You know, so how do we do it in radiotherapy?
Well, what improves the quality in countries like the UK, which is predominantly tax finance, is political pressure to fund it properly. And you know, you heard the government announce just a couple of weeks ago in the budget, £22 billion for the NHS, you know, so which one hopes is going to improve the volume of services, but also the quality of services. But Wes Streeting is making it very clear that he wants to see efficiency improve as well. And whereas I've obviously been talking about public financing, I wasn't necessarily saying that all the services have to be publicly provided. And there are many very good health systems, France, Japan, where actually the bulk of the providers are in the private sector. But you're using public money to purchase good quality services, be that in the public sector or the private sector.
Yeah, and being able to plan in 24 hours. Yes, it would be great. Look, that is absolutely fantastic. So it sounds as though we've just got to keep advocating at political level. And presumably in your new role, you're available for advice to the radiotherapy
Absolutely.
community.
You know, at LSE, you know, we are sort of specialising in this area of work, you know, to take all the great work you're doing and sort of trying to present it to policymakers in a form that they like and understand, and more internationally, to be perfectly honest. But thinking of sort of Uganda and Nigeria and Ghana, you know, we're active in all these countries.
Same old thing. So join the family. Marvellous.
Fantastic.
Thank you ever so much. Then, great. And now we've got Katie Spencer, who's going to she's going to talk about the wonderful radiotherapy data sets and her new role. So we're going to be wowed with data. Thank you, Katie.
Thank you. So I wanted to talk to you about the role of data in delivering quality, sustainable radiotherapy services. And I'd like to go back a step first and say, well, what is quality? And the World Health Organization has helpfully defined for us quality in healthcare and state that this should be effective, it needs to be safe, it needs to be patient-centred and timely, it should be equitable, it should be integrated, and it should be efficient. So what does that mean for radiotherapy? And how can we measure that using data? Well, let's go back to effective. We can think about increased novel technologies or newer technologies now, IMRT, arc therapy that deliver highly conformal treatment. Well, are we all delivering them when we should be? Let's use data. Let's find out. Are we doing that across the patch, across our country, across jurisdictions? Is it safe? Are we delivering radiotherapy so close to the end of life in the palliative setting that our patients may actually be experiencing more harm than good? Let's look at early mortality. Let's check that that is not what we're doing, that our services are getting our patients to us such that we can actually treat them and deliver that benefit that we know palliative radiotherapy offers. Are they patient-centred? Well, everybody is different. Maybe in some cancers that's less of a problem, as Lauren said, but in other cancers, actually, there's really big variation, and we need to be doing peer review of all of our plans to ensure that the weakest link, that's us, the clinicians, is actually getting it right, and we're getting that patient-centred care that is right for the individual. So let's use our data to check that we are doing appropriate peer review. We've mentioned timely many times. The NHS obviously has some pretty standard measures of timeliness in terms of time from diagnosis to treatment. But actually, why don't we take that a step further? When we start thinking about integrated services, let's not think about just time from diagnosis to treatment. But if you've just had surgery and you need adjuvant radiotherapy, how quickly are we getting there? Let's integrate our data sets, bring radiotherapy data and surgical data together to start thinking about pathways and not just a diagnosis to a treatment. Importantly, though, we're thinking about efficacy, safety. That's great. But what if you don't get radiotherapy? What about equity of access? And this is absolutely key. And there we need linkage to cancer registration data. We need to know who's out there, who is eligible for radiotherapy, who should be getting radiotherapy, and are we managing to deliver that? Let's look at that, again, across our jurisdictions and within them to understand where the variation is and use these data to really highlight where do we need to go digging? What are the issues that are causing this variation in access that's been beautifully highlighted? And how can we address this variation? And then finally, we've talked about funding and the lack of funding and the need for services to be efficient. We're in a fantastic position to do this in radiotherapy. We've got a burgeoning amount of data supporting our ability to deliver ultra-hypofractionated treatments, minimising treatment times and patient burden. The service wins, the patient wins. But are we doing it? Are we doing it routinely and all the time? Again, we've used these data to be able to look at that when Fast Forward came out with breast cancer hypofractionation in the pandemic. The vast majority of providers took it up immediately and we switched. But not everybody. But by showing that not everybody did it, you can go to those providers that aren't doing it and say, do you realise that you're the outlier? Everybody else is already on this. And actually that's really powerful. So bringing best practice from one place to another, using the data to highlight where is this best practice? What can we learn from you? How can we improve and get better? And ultimately doing that not just within our jurisdictions, but hopefully beyond and between jurisdictions.
Great. Data is king. That's what we need.
Data's always king.
And I think there's a... Oh, Neil.
I wondered if I might ask a question.
Go for it. Neil, it's lovely to see you.
We will have time for questions at the end too.
It was because of your fantastic presentation about data. I thought I'd ask the question right now, while everybody's thinking about data. I wanted to ask, has the government understood the power that data will give the government in terms of decision making about, well, funding and actually calling us to account if we're not being efficient enough?
I think that's a really interesting question, Neil, and I think it goes back to Rob's sort of comments about how do we use these data and how do we better communicate them so that actually we understand what it is that policymakers and politicians need to inform their decisions, and we communicate in such a way that we use our data to get the right message across. So I think it's two-sided. It's on the politicians and policymakers that we need to identify, and we need to understand what they need. They need to tell us what they need, and we need to communicate in such a way that they understand we know this and we can support them. And at the moment, it sometimes feels there's a little bit of a disjoint there. I think we just need to get better at that on both sides of the equation.
Great question, Neil. And I think the fact that you are the national clinical lead on radiotherapy data is a start. Yes. And I think obviously they will be concerned, as you quite rightly say, about our targets at the moment. They'll be a bit scared of what the real data does show them. But I think if we can give them confidence that we can work and make it better, and this is the way forward, you know, being honest and transparent and knowledgeable, it is the way to do it. And I also think we can lead the way, because I think all those years when radiotherapy data sets started, I remember all those times, it's because we can get the data straight off the machines. That was the, you know, and that we mustn't underestimate that. So I'm thinking of the low and middle income countries. It's all about putting it right in at the beginning. Get the data. When you're thinking of doing something, you get the data immediately because you're going to do the decision making, you're going to do the implementation science. So it's great. So no pressure, Katie. We're expecting great things. But thank you, and I hopefully come back again and give us some data. Okay, so that's fantastic. Okay, so now Habib's going to talk to us from Electa, and he's going to talk about service development and commissioning and support. We're delighted to have you fly over for us. Thank you.
Thank you for inviting me here, and I'm Habib Demi. I'm the Chief Commercial Officer of Electa. When listening to the presentations here, our Siemens Health senior friends, I realized that we're talking about the same thing. So it gives me the impression that we have no competition. We have our own competitor is cancer, and this is what we are about. Over the last 3 years, even during COVID, as implementing the strategy of Access 2025, we have given access to more than 280 million people new access to radiotherapy, and the majority of this access are in emerging markets or low and medium income countries. And we realize that many countries received these systems were the only and the sole systems, and therefore puts for us a lot of burden how we ensure that we have a sustainability of the solutions over the life cycle of the radiotherapy equipment. Unlike other medtech equipment, the radiotherapy has a life cycle of 10, 12, 15 years. It depends on the country. So therefore, what is very important and what we learn is to look beyond the transactional or beyond putting a system, is how we can ensure that we have operational system with full quality of delivering the dose and in an uninterrupted way. So therefore, the design of the project from the beginning is very, very important. The awareness about the different regulations in each countries of these emerging markets is key to anticipate the issue and to put the planning for that. So the funding, as well as has been reported here over the life cycle, how are we going to sustain the serviceability and the full operation of the system is key. So I come from the beginning is how to make sure that we have the right design, the right implementation of the bunkers, because these are greenfield, meaning in many circumstances, this is the first system in the country or in the hospital. unlike mature market where it's a replacement. So the users or the investor or the hospital has to figure out all the cycle and integrate it into flawless operation. So therefore, I mean, either from the construction's point of view, having specialized constructors that the vendor can bring, or that other consultants can bring that have done it before and made sure that from the first time they have the solutions. Figuring out how they're going to work with the governments, with the importers, in order to ensure the serviceability and the importation of whatever needed to make the equipment operational with uninterrupted way, because we cannot interrupt the treatment. Training is essential. Pre-training, I mean pre-installation and after the installation, along the life cycle. So therefore, we cooperate with bodies like the Atomic Energy, International Atomic Energy, to have anchor centers and common training and awareness in these countries. The digital platform is key as well, because a lot of support of service is remote. We have around like 40% of the cases can be fixed remotely or in a predictive way. So training either of the personnel or of the technical engineers are key. Having a local strong partner as well who can understand the issues and the particularity of each country is key. So overall, what would like to say that, respecting my time, it's not about only selling the equipment, is about implementing a solution overall that is operational.
Thank you. And you're right, it's not about just selling, because I must say, you know, yourselves, you know, and Varian as well, that contribution you've made, like to the Global Coalition, really with us as partners, you know, I feel that clinicians, all the technologists working with industry, it is a complete partnership. It can't be anything separate. So, and you made a very good point there about the IEA anchor centres. I think they're going to be really important, aren't they? So I was just thinking, and the point we made about training, as you've made as well from Varian, about the appointment to train, how far do you think you can go with that? Could you go? I'm conscious that I know some United Imaging in China, they did some centres where they actually had their own technologists and send the machine, have some radiographers as well. How far do we go with that, or is it just training? What you know, are you the ultimate solution? Here it is.
I think it's a holistic one, is getting as well, working with the academy to have to integrate the right programs for medical physicists, radiation oncologists, pre-training as well, to make sure that they are aware of what does it take to have a radiotherapy system. So in that case, having curriculum with the IEA in some markets is key, having these anchor centers, cross trainings as well, having regional centers for training, theoretical but as well practical, and definitely post-installation during the life cycle, where we have advancement of techniques. I mean, even in emerging markets, I mean, we need to use VMAT, because we need to use hypofractionation, because shorter we do the exams, but it is for the patients and in order to. So I would say integrating it in the curriculum with the academies and post-graduate as well training, but at the same time I would say with the IEA, but as well as a company, we have a responsibility to ensure that we have a curriculum to make sure that they're using the technology at its utmost.
And is there any way us as treaters can interact better to support industry in their efforts there? Is there anything we could do better?
I think this is part of the development of the companies, is that to have a feedback about how we can improve the treatment, what type of new features. I mean, we talk about AI here. It's extremely, I would say, key, and we're, yeah, I mean, we should develop equipment and technology that address needs of the clinicians, ultimately. So voicing the user's needs is our focus. I mean, we develop based on what please or make the life easier for the user, not for the engineers.
Yeah. Great, thank you.
Thank you.
Again, thanks for coming with us. Good. It all gets back to communication, doesn't it? Okay, now, implementing quality radiotherapy. So, delighted to have Frédérique come from Accuray. I always love her European outfits. Always sparkles us. So you're going to tell us about how industry partners can drive up quality improvements. Thank you, Frédérique.
Thank you very much, Pat. Thank you for inviting me. Hello, everyone. So what can industry do to have an impact on quality improvement and access to radiotherapy? Certainly by introducing advanced technologies with high precision supporting cancer control, lowering toxicity, and improving patient outcomes. Here we go. Come on. Here we are. Here we are. For instance, taking the example that was shown before using AI-driven capabilities, such as real-time tumor tracking or adaptive radiotherapy, that enable extreme precision and personalization of treatment. Also by supporting practice changing, such as hypofractionation, which provide efficiency benefits for to start with for the patients who can return to their normal life quicker and have to travel less to the hospital. Also for the healthcare system with increased patient throughput and possibly compensation for staff shortages, and also for the society with higher productivity. Higher efficiency may also come from reduced planning time to possibly allow doing on the same day planning and delivery of treatment. And also it's possible today to have significant reduction in commissioning time, that is methodical, lengthy process. So it's possible to reduce by 50% the long time it usually takes. Impact, access and quality of treatment can also be done by offering differentiated solutions, either dedicated solutions to some techniques, but also universal solutions that offer flexibility and versatility to the centers. With platforms adapted to the country economic status and needs, so more advanced or more so-called access type of platforms, and then offering some unique technologies, robotic, helical, for instance. Besides technology solutions, there are also other modalities that have been developed earlier, such as training, offering training in person, on-site, virtual, offering complete training from commissioning up to the first patient and even beyond, and offering training facilities that are spread worldwide in different regions of the world. Offering solutions that include maintenance and spare parts, as it was said earlier, platforms that allow connecting users and their peers, and contributing also in advocacy activities as we do today. I just would like to finish by sharing two great experiences that we had respectively in Pakistan recently and in Kenya. We've been very lucky at Accuray to have this long-term partnership in Karachi at GPMC hospital, who first installed their first robotic device in 2012. And this really supported a lot of Muslim donation to their Patient Aid Foundation. And this has led to setting up more machines, including the latest generation. Treatments for cancer and also for functional disorders, they are delivered free of charge to the patients from 15 countries, and there will be more to come, regardless of nationality, religion, and ethnicity. And indeed, the quality of the treatment is very much driven by the hospital governments, the training and audits that are performed by international peers. In Kenya, there is a national cancer plan and also a national health insurance fund, but not everyone is registered at all, and also patients have to travel long distances. The goals of the hospital in setting, especially the radiotherapy center, was to have a comprehensive cancer center with a radiotherapy center with one LINAC, brachytherapy solution, and one CyberKnife. They have been willing to decrease the outbound medical tourism and also to increase the inbound medical tourism to generate income from private and overseas patients. Reduce also travel costs for patients thanks to hypofractionation, reduce waiting lists, and the hospital has been very much highlighting the importance of training and continuous education. Thank you.
Thank you. And actually, it's very important, isn't it? Because really, CyberKnife, you know, name it, did bring the wave, didn't it, in terms of precision? And I remember I was trained on CyberKnife a long time ago, but it led that way and it allowed more hypofractionation. I'm conscious that the IEA with the Lancet Commission on Radiotherapy came out, basically their conclusions was hypofraction is the way forward to accessibility. Interesting in your example that actually you can get more patients to stay or even treated in, because we know in some countries the solution is travelling in somewhere else. So how much do you think, and for all of industry, we should be going to more hypofractionation? Well, but we need the precision. We can't just go hypofractionation. You know, we've all seen that. Where do you think industry should go in terms of that?
I think we really have got to understand the needs of the country, the healthcare system, and how this can be implemented. And with training, as you said, you cannot just get started with hypofractionation without being well educated, educating fully the team. So it's kind of we also have got to work based upon previous experiences. Our experiences in Kenya as well as in Pakistan and in other places are really eye-opener to us, and we proceed step by step in learning, in networking, in getting to know much more the country, again, the economic status and the needs that they are.
That's it's really important. And I suppose to also have confidence in it. I remember not that long ago, 2018, one of the powers that be I was talking to said, SBRT, oh, it's very difficult, very dangerous, you know, very careful, as in we're not funding it. So I think it's to have that confidence. And again, it's like with the AI, you've got to have your checks and balances, but if you get it right, gosh, great. Frederick, thank you so much. That's lovely. It's Lisa from the IEA, and he's going to National Cancer Plans. I'm with you there, yes.
Thank you, Pat. I'm delighted to be here, and I'm actually happy that I'm not the first person who's mentioned National Cancer Control Plans today. So thank you very much to the other panelists. So I do want to talk a little bit about what is National Cancer Control Planning. There we go. So it's a strategic approach to looking at the country's national needs, gap areas, and putting together a strategy. And others have mentioned some discussions we've had earlier this week. A plan is just a plan, and if you don't implement it, then it's a document that, that's not going to help the country. But it's bringing together stakeholders from across the cancer care continuum, and that's why I wanted to ensure that we had the whole cancer care continuum. So I know we're focusing today on radiotherapy and the affiliated support. Radiotherapy cannot stand alone. It has to be well integrated into a health system, and that's really what I think the value of national cancer control plans are. We have to involve the various components to ensure that there are policies developed, there's training plans, infrastructure, in order to integrate radiotherapy, diagnostic imaging, all aspects of the cancer care continuum together. And we found at the IAEA, through our work with the WHO and the International Agency for Research on Cancer, that the basis of a plan really starts with an assessment. One of those types of assessments are the impact reviews that we do jointly with these UN partners and other partners in country like City Cancer Challenge. We're working very closely with some of the US cancer centers to provide experts. But this baseline assessment are evidence-based expert recommendations developed jointly with an international team of experts and a national local team of experts who know the situation to be able to provide recommendations on what might form the basis of a plan. And again, we have to make sure that the facilities visited are looking at prevention, are looking at screening, the diagnosis, that accurate and timely diagnosis so that treatment can be provided. So my second slide, maybe some of you are sitting there thinking, why is IAEA talking about comprehensive cancer control plans? Well, we do have technical experts in the fields of nuclear medicine, radiotherapy, diagnostic imaging. We also have my division, which is in the Technical Cooperation Department, that works with WHO, with IARC, with our internal technical team, and with international experts. So IAEA really focuses on the part of the cancer continuum that involves the diagnostic imaging, radiotherapy for treatment, and also for palliative care. And we work with our radiation safety and security experts within IAEA to ensure that this is delivered safely. Both patients, providers, the environment, all of that is considered in terms of radiotherapy. And we have Rays of Hope initiative, thank you, Habib, for mentioning that, which is looking to help countries either initiate or expand access to radiotherapy, because we're hearing today that there's, even in countries that have radiotherapy, there's usually not sufficient coverage. And so Rays of Hope is a technical initiative that brings diagnostic imaging and radiotherapy to countries and works and integrates into the WHO global initiatives, so the Cervical, Breast, and Childhood Cancer Initiative. We have the Joint Program in Cancer Control with WHO, and we're also linked to the IARC Global Initiative on Cancer Registries. So there is this need to work across the cancer continuum and integrate multiple specialties into this cancer plan. And the last thing I want to say is about communication. So we've talked about how do you communicate the priorities. When you have a plan that has clearly articulated priorities and hopefully also a monitoring and evaluation strategy, so you can get those benchmarks out there, you can talk about your scorecard to implementing your plan. And when I first started working in this space, we would hold cancer control leadership forums, not only looking at the plan, but how to build that leadership from across the cancer community to be able to communicate what those strategies are. In the case that if you get into the elevator with the Minister of Health or the Minister of Finance, you can clearly articulate what those priorities are. So thank you. 4 minutes goes so fast.
I was impressed. Can I just ask, Rays of Hope and the anchor centres, what have you learnt from that? What can we transfer to other places? What, fundamentals?
So we're still rolling out the anchor centers. We have about 10 that have signed agreements to serve in this capacity, and it's a regional center that supports training. And I think, the colleagues have talked really about the essential need for more training using the IAEA standard curriculum across these areas of expertise, but also to provide expert for quality assurance missions. And thank you for talking about data. Also to participate in research and innovation. So data collection, how to utilize that, and how to talk about, the hypofractionation or other opportunities within the research space that the technical team at IAEA is overseeing.
And a very good point, because I think silly, we didn't mention it, we should have done. Research must be integral to all of this, because radiotherapy development is all about the D end of the R&D and must be ingrained in everything we do.
Right.
Great, Lisa,
Okay.
great.
Thank you.
Yay, cancer plans, yes. That was just because yesterday Richard Sullivan went off on one and said, what about something wrong with cancer plans? Oh, we killed him. Right. Okay. Finally, it's an absolute pleasure. We've got our next speaker, Amika, online now from the aortic, telling us about training and education. And thank you very much for joining us remotely. So fire away.
Yes. Hello. Can you hear me?
Yep.
Just to confirm that. Okay, thank you so much. So thank you for inviting me here, and thank you for the opportunity to give this talk on behalf of AORTIC. Just a brief introduction. AORTIC is the African Organization for Research and Training in Cancer, and as the name is, that's essentially what our motto is. So I'll be talking, next slide, please. So I'll be talking about how education training can improve radiotherapy. And this slide, I think a colleague earlier on presented the infographic that shows clearly the deficit that exists in many LMICs, particularly in Africa, in terms of the infrastructure that is required. And also, since I'll be talking about training the manpower that is needed to provide safe and effective radiotherapy services to many of our patients. As we all know, many of our patients presenting locally advanced metastatic stages, increasing the need for radiotherapy. So it's really important that we're able to offer this service at whatever stage that they're presenting. So just to give a little background on where we are in terms of Africa and the human personnel that we have, according to the DIAC for Global in 2020, it shows that there's a shortfall as it is globally, but particularly in Africa, where we have, there's a shortfall of around 39% of radiation oncologists that is required to treat the people with cancer. Medical physicists, the figure is around 68%, and then the therapy radiographers, it's about 67% of shortfall. And then it's projected that, especially now, with the increasing incidence of cancer globally and particularly in Africa as well, we would need more than 12,600 radiation oncologists to be able to provide safe and effective service to the patients, and more than 10,000 and then medical physicists and 29,000 radiotherapists. Bear in mind that to be able to provide these services, to be able to provide this manpower, it takes many years to be able to train a radiation oncologist, 5 years, actually, medical physicists and RTTs. And then when we talk about where this training is on the African continent, there are about 12 African countries that have very well established radiation oncology training centers, training programs, and only 9 African countries that provide training programs for medical physicists as well. So when we look at the proportion in terms of the IAEA stipulation of 1 to 200 patients, for instance, in a country like Nigeria, where I'm from, with the projection of around 125, thereabout 1,000 patients. And we know that is also not very accurate. We have a little under 80 radiation oncologists. So if you put the maths, we're looking at around 1 radiation oncologist servicing around 1,500 patients. So we can see already the strain that provides in terms of being able to deliver effective services to the people. Next slide. So to be able to deliver this service, okay, I think that's from N3. I haven't changed. Okay, right. So what are the key drivers that will support providing quality radiotherapy and improving productivity? Of course, we know that there's need for clinical skills training, and there are a few examples. We've talked about the IAEA, talked about some operations with Kenya that was highlighted earlier on, and there are a couple of others on the continent, and IOTIC is also working closely with some of these organizations and in country to be able to provide that. Same thing also with continuous professional development. At Celtic, we have a radiation oncology special interest group where we occasionally run programs. We finished one brachythera on brachytherapy, 3D brachytherapy for cervical cancer. So we know that these are some of the key drivers that can help us bridge that gap. We've talked a lot about technology, and we're looking at how we can use technology to bridge the gap as we try to ramp up training. And there's also need to look at mentoring programs. There are collaborations, successful collaborations that we had that have improved capacity for skills and for research. I think Katie talked about the need for data, and data will ultimately inform policy and practice. IOTIC partnered the Clinical Research Mentorship Program. This will be the second year now to try to improve skills for research among the junior residents in radiation oncology. So these are some of the examples that we see as key drivers that facilitate provision of quality radiotherapy services. And we know that once this is done, the impact will be for improved patient outcomes through precise and effective treatments, efficient use of resources to reduce treatment delays and wait times, and also consistent adherence to treatment protocols, ensuring high quality care. And this we are able to achieve using a collaborative approach. We have international partners that we are working with to be able to do that, and also at the regional level. And we're very happy with the sites that has been talked about, because we think that if this will help to build regional capabilities and skill sets on the continent. So I think I'll just stop here for want of time.
Annika, that was fantastic. You're doing such a lot of fantastic work there. One question I had was about professional bodies and accreditation in terms of training. How is that working out where you are?
So there, like I said, there are only 12 African countries that are providing training programs. Again, the training programs typically would help them standardizing the practice, and these are the only countries that perhaps have the skill set to be able to provide any form of accreditation. But even as I say that, most of the accreditation that we have with the labs, the physicists, actually come from international collaborations. I know that IOTIC is looking to see how we can work with the people on the ground to establish regional centers that can help with standardizing the practice and helping with accreditation, because we know that once that is done, it will improve productivity, will make sure ensure quality services are being provided to the patients. And we think it will also improve patients' trust as well, to be able to go to these centers to access care and ultimately reduce the brain drain that we are currently seeing on the continent.
Yeah, no, thank you for that. And that's important about the trust and also about the brain drain as well. No, thank you very much. Well, look, what a fantastic rapid fire session. Let's give him a round of applause for now. Yay! And putting up with me interrupting you, but then should we give the audience a bad time now? Yes. So I'm going to open it up to the audience, but also we want some questions. Otherwise, I'm going to ask you some questions. Here, the front. So if you say your name and then tell us your question. Thank you. Oh, here. Oh, question here.
Mohammed Mir, National Physical Laboratory. Thanks to all of the speakers. Common thread throughout of that about learning and training and the importance of research and application of data, so on and so forth. And Solomon, really interesting slide, the one that looked at barriers. Yeah. And I thought we were talking about England and the UK for a minute, following the APPG report. So I think, again, the barriers are common. For me, I suppose the question to the panel would be, would you, in light of that, the barriers, see Lord Darcy's report as an opportunity for radiotherapy? Because I think if we look at the three core issues, I suppose improving efficiency in secondary care, improving treatments, improving innovation, for me, radiotherapy is the perfect answer. And it's how we get that narrative. So I'll shut up there because I could go on forever. So I'll let you speak.
Yes. Who'd like to answer that? Yes. Yeah, yeah, go.
So I need to make sure that I understand well. The question is that how we can make the, I mean, in a sense, how we can accelerate trainings or how we can transfer knowledge or...
I think it's the point. Lord Darcy here did a report saying the NHS is rubbish, here are all the solutions. And I think a lot of us are thinking is that radiotherapy's got a discrete community. We've got the technology, we link with industry, we've got the digital, all this sort of thing. Isn't that your exemplar of this is how to solve it? Which would do for the whole world, really.
And we're missing that political link, I think.
Yeah, I agree. And this is represented as well when we look at the investment done in radiotherapy within the overall oncology investment. It gets the lowest part, which is 7% of the overall, and even maybe less sometimes. So, I mean, we thought that key opinion leaders in radiotherapy and those who can move things, the barriers, and important governmental affair as well is to lobby with the governments to make sure that we have a national cancer plan where radiotherapy is key inside. And more, I mean, we have medical evidence about, but you were talking, Pat, about a couple of years ago, SBRT was not perceived to be the way to go, but maybe because now with more advance of the technology, more precisions in radiotherapy makes this barrier, I would say, further. So, yeah.
Sorry, and I think a lot of time, poor communication, that was said by somebody, frankly, who knew nothing about radiotherapy. Actually, I was wondering if I could ask the audience this as well. Yes. Sarah, I'm going to ask you. So this is, sorry, I'm going to pick on you all now. So Sarah is director of the charity Radiotherapy UK, and that Radiotherapy UK is secretariat to an all-party parliamentary group on radiotherapy. So we have engaged politicians. So what do you think, and again, for other people, we're lucky we've got an advocacy group in the UK. For other countries, what help is an advocacy group or an all-party parliamentary group on something like radiotherapy? How can that help?
I think it's crucial that you have the advocates within Parliament. So what the APPG for radiotherapy, it's a group of cross-party parliamentarians who come together to advocate and raise the awareness of radiotherapy. So they're in the room of the decision makers, and that's critical. But what that then gives us an avenue to do is bring in the experts. And whenever we talk about experts, we're talking about patients, we're talking about the clinicians, the workforce, and industry together. And I think what is quite unique about radiotherapy is that there is a really strong community. And I've worked in other areas. Radiotherapy is not my background. And I am always surprised at the synergy between the different areas within radiotherapy. And that is something to enhance and to grow and to develop whenever you are speaking to the government. And it is very much also what Lisa said there, know what you want to say, because you do not know when the opportunity will arise to influence. And you could find yourself bumping into somebody who has influence and can make decisions on the bus or just on a walk, as well as in the places of power. So know what it is you want to say and know what you're asking for. And cancer control plans are a massive step towards that. But within radiotherapy, it's really important as well, which is why I think events like this, the sort of like global radiotherapy community coming together, the World Radiotherapy Awareness Days, really helps us as a community hone our message, know what it is we're asking for, and then when we get in front of the right people, everybody's singing from the same hymn sheet.
Thank you. I'm sorry to jump on you like that. But also, I'd quite like to jump on Willie now. Sorry, Willie, you're in the firing line. Willie works for Tendo Consulting, who's actually a lobby and also political insight. So you've got some, in terms of getting to your point about how we should engage and much more, just give us 2 tips on what we should do. Probably get some professionals like yourself to help.
I think just having that short, sharp message and knowing that ask ahead of time. So when you do get in the room with MPs or people who can make a difference, you know exactly what you want to say. And just having a big group like this and being able to, lobby all across the country and being able to, tap into various communities, whether it's patients or it's industry or it's academics, and having all of us kind of singing from the same hymn sheet is very important.
Oh, thank you, Willie. Sorry to jump on everybody. Kofi, saying.
Thank you, and thank you, the panel members. So I want to find out from Varian, Electa, and Acre, right? They are taking care of our machines. So in our setting in Africa, sometimes machine breakdown, it's a serious issue for us. And I want to find out how they can, together help, Currently, I've gone through most of the Africa countries. We've done recently a publication with IAEA, and sometimes a machine can be down for 6 months, and you don't have them to come in to help, put up. And you can imagine, few machines, but it breaking down constantly, so I want to see how best, we can, engage you people. Thank you.
So, Varian, yes.
Try to address that. I think, can you hear me well?
Yes.
So, I mean, as I was mentioning before, the machine being down is a outcome of many factors that is impacting that the machine is down, right? And there are many aspects to it. Obviously, the obvious ones are pretty clear, right? But the important point, which I was also mentioning probably in between the lines, is, we need to make sure that we have a specific budget for maintaining the machine. I think apart from all the obvious ones which are there, a lot of times the awareness among the various stakeholders that maintenance is going to be required for 10 years. You buy the machine on day one, but maintenance is going to be required for next 10 years, 15 years. And there is going to be a need for budget for that. I'll give you a practical example. There are cases we have seen where clinics buy, for example, 5 machines, and they don't allocate any budget for the maintenance. Compare that to having the awareness and buying only 3 machines, put the remaining budget on the maintenance for next 10 years, and you have a seamless possibility to treat the patients over the next 10 years.
Yeah.
I think that is, important part for me in terms of awareness that there is a requirement for some budget over the years.
And I suppose that gets back to Lisa's point about having a cancer control plan, but the granularity within that of a radiotherapy plan, and the granularity within that means maintenance, and this is how you're going to, which we'll get onto it later about the Global Coalition talking about the essential standards, and that should be just to say, because as you say, buy 3 machines and get the maintenance, otherwise you're down for 6 months. That's sort of, any other comment from industry there? I don't know, BV, if you wanted to say something.
No, I think in these countries it's important to have 2 machines that match each other, because you cannot interrupt the treatment. So it can happen that machine goes down, but another machine, because it's matched, so it can continue. A remote diagnostic, predictive as well, maintenance, predictive way of knowing what the machine health is, how it's going, and anticipating a failure. Having as well a strong local partner, and this is what we do actually, making sure that, because we cannot fix it remotely. So yes, but it's not acceptable to have machine downs. We have as well some hubs where we have a big markets where we have the majority of the engineers based there. They can fly, within 1 hour, 2 hours to repair. But funding is essential. I agree on that. Yes, yeah. And it's our job to consult before selling, because even if it's not as a vendor responsibility. But it doesn't make good for the patient and nor for the branding of the equipment to be down, yeah.
Lovely, thank you. Questions? Andy, you had a question. Yeah. Sorry, and then I'll come to you. Yeah. Andy here? Yeah. Oh, sorry. Oh, sorry. I should take you in a different order. I'm so sorry.
Thank you. Can you hear that all right? Yeah. Yes. I'm Andy. I'm a patient, so I've had successful radiotherapy. I don't know if I'm one of the few in the room. So I want to advocate for patients. I'm pleased that a number of you mentioned the patients, because that's important. So in an ideal world, it'd be great if the first time someone hears about radiotherapy isn't when they're told they need it, because the brain is not functioning at that point. So in terms of raising awareness to get people into the pathway earlier and quicker, raising awareness with the sort of the GPs in the hospitals, and politicians as well, how can we do that? Because one thing that springs to mind is recently Chris Hoy went live with terminal prostate cancer. And I think following that, the traffic onto prostate cancer websites went up 8-fold. So I'm not saying that's a solution, but how do we, and because of that, more people now know about it, and they can put pressure on their politicians and their GPs and say, how can I find out about it? How can we do the same for radiotherapy?
Yeah, so that gets back to we've got to say cancer more, haven't we? And we've got to say it's okay to say cancer, and then we've got to say it's okay to have radiotherapy. I think we just have to keep at it. That's my feel. Although still, number of times we've tried in Parliament, can you get a politician to stand up and say radiotherapy rather than radiology? No disrespect to our radiology colleagues, but we're getting there. So I suppose, again, asking the panel or the audience, is there any tip? We've got to normalise it a bit, haven't we? Because if you're scared of something, you don't talk about it. But in some ways, perhaps you guys are the best things to do it. I've had radiotherapy, look at me. Any other thoughts or any other techniques people... And I'm thinking particularly in lower middle income countries as well. We're talking about trust and communication, fear and cultural and religious beliefs or whatever. How are we going to do that worldwide? Solomon, no pressure.
Well, actually interested to hear from your side, because in our side it's such a more challenging. Yeah. I totally agree. Many patients will hear about radiation for the first time when they're referred to radiotherapy department. And not only patients, but even practitioners do not get exposed to radiation oncology earlier within their training. So it's still a vague concept compounded by the stigma around cancer.
I think you've got a good point there about, Lisa, about other clinicians. I remember we had, I think, my training, about 3 weeks on cancer, radiotherapy with those people in the basement with the black marks on their head. And I'm not sure, even my own clinical colleagues, I'm not entirely sure they get radiotherapy now, or understand it, or think it's the jump we've had from high-dose precision, lack of toxicity, I just don't think people get. And in some ways, they perhaps see the people who perhaps had wide field radiotherapy with hypofractionation 10 years ago and obviously have some side effects. So there's a real messaging there, isn't there? Lisa, tell us.
So I want to sit in the audience now as an American, not in my official seat on the panel, and say, direct-to-consumer advertising in the US of pharmaceuticals has driven demand. And I've also seen riding around on the tube this week something about PSAs, public service announcements. So I think there's an opportunity, what you're talking about, Dr. Solomon, about outreach in that, the consumer, let them be aware of it before. Also in the US, St. Jude's Children's Research Hospital has ads all the time. So people know if your child has cancer, they know that there's a place to go. And I think MD Anderson also has a good public outreach. So that's an idea, again, in my public response.
No, fantastic. Yes, yeah.
I was just going to talk about ICON's experience in China.
Right, interesting.
And I think it was mentioned potentially today or yesterday, but there was a very, very, very poor perception of radiotherapy in China. And that was because of probably how it had been administered. So what we found is, as we entered as an Australian partner with a range of hospitals into that country, patients were coming to us to ask, who are you, how are you doing it? They were very interested in the technology. So I think sometimes we need to not underestimate, excuse me, the sort of research that patients are doing now. But also you're referencing maybe they're looking at those things at the time of care, but then I think the way for us to tack on to that is to then engage with the families of the people who are supporting that particular patient who has the diagnosis, because I think it's very difficult to just go out there and talk about the changes in radiotherapy are incredible, but I think they're very hard for the general public to really understand how much it's jumped in, say, the last 10 years and what that means for patients and side effects. So I guess reflecting on the China experience, it was really about actually, okay, the patients who are coming to see us, but actually then starting to educate the family who is always with them, the nursing staff who are also taking care of them, and the other hospital staff as well, as we started to implement those services there. So you almost need to do the local initiatives as well, because I don't think patients are looking before they need it about what radiotherapy is.
No, good, thank you. And another thought there. I must say, sometimes I think it's wording, isn't it? Say robotic and AI. Very cool. Yes. Add it to everything.
Just to state the obvious, I think you need political champions. I mean, I think the example of Chris Hoy is a very good one, and you need an equivalent, you know, in this day and age with social media and getting the attention. So I think, you know, amongst the community, so sort of to find sort of prominent people who have successfully had sort of radiotherapy and really encourage them to do right by the whole movement and sort of get out there. And you know, you think of recent examples of things that have rocketed up the political agenda, say like mental health services and you know, the royals pushing that, you know, particularly Prince Harry and Prince William. And I mean, I don't know what the situation is with His Majesty the King or with Kate, but were they to have had radiotherapy in their treatment, to encourage them to go public on that would be an absolute game changer.
Certainly, I know in the UK we have Brian Robson, of those who apparently he was the David Beckham of years ago. He's been great, and also we've got a gold medal athlete who, as he says, his spinal medulloblastoma, radiotherapy literally saved his life, which is a great advocate. Francois, and then we'll move to your question, sorry, and bring Aotik in.
Yes, I just also would like to emphasize that this is exactly what we try and do here, is to put radiotherapy on the public place. And I have some experience to share about Eastern Europe, especially in Poland, where there is a great cooperation with patient organizations. Several organizations have signed letters of agreement to work together on emphasizing the role of radiotherapy in cancer treatment, and they are really the ones in the forefront. Industry is there, but just in the shadow, and that's patient organization who are really talking, as well as with experts, radiation oncology experts, and they are, for instance, each time it is feasible, there are webinars organized during November, Pink October, or during Lung Cancer Day, or whatever. So experts in radiation oncology are talking on websites that are very well known by the public, medical websites, and talking about radiation oncology in lung cancer treatment, in breast cancer. But everything is done in cooperation also with patient organizations who give their experience, who ask questions with live participants. So, yeah,
I think it's that collectivity. I sometimes think it's actually, again, in the UK, we've been lucky to have the patients, all of you on the industry task force. Brilliant. You've turned up time and time again, year after year, in parliamentary events and speaking. But I felt the last one we had, before you'd have MPs coming in saying, what's radiotherapy? This time they came in and they said, you know, my centre's radiotherapy. They kind of knew it. It's taken a long time, though, hasn't it? Taken a long time.
Health economics works. I mean, having economical, showing evidence about the cost and the outcome. This is economical evidence could be impactful.
No, I think that's right. Okay, we'd like to move on. Sorry. Oh, yes, I was going to bring Amika in, because if the mic goes down there for the second question. Amika, you wanted to come in to respond to Kofi, yes. And then we'll come down there. Amika? Sorry,
yes, so I don't know who Kofi is now, but I just wanted to say I was typing in the chat that when the question came around advocacy, and I just noted in the chat box that I think that advocacy specifically for cancer for radiotherapy is important. And I know that for us in Nigeria, in the last maybe like 6 years, maybe 6, 7 years, we had typically had only maybe like 2 to 3 radiotherapy machines, linear accelerators in the country. And most of the time, like my colleague in the room mentioned, in terms of downtimes, typically we would have only like 1 or 2, maybe 1 really at best functional. But with the upsurging of the voices, the advocacy efforts from civil society organizations, the Nigerian Cancer Society, the association bodies like ARCON, the Association of Radiation and Clinical Oncologists, and also some other NGOs like Medicaid Cancer Foundation and some pharma companies were able to really put pressure on the government. And between then and now, we have 15 more linear accelerators in the country, and there's a projection of an additional 20. So just to say that it's really important to get people interested who would speak and continue to apply pressure from outside as well as within the chambers as well. But then I had a question now that I have the mic, talking about maintenance, because like Lisa mentioned, we recently concluded our IAEA impact assessment review, and we're engaging with some of the private facilities. They mentioned the huge cost, the cost involvement for maintenance. And I think, yes, they had built for it, they had planned for it and put it into their budget for over the years, but then with the fluctuations in the dollar, there was a problem. But the real question really was that for some countries outside of Africa, people in getting those radiotherapy machines, they didn't have to buy outrightly. So for the vendors that are there, the manufacturing companies that are there, can there be, now that we're talking about advocacy and we know the huge disparities that exist in Africa and many other LMICs, can there be tailored funding solutions that come from higher up that allow people on the ground to be able to lease those machines and free up more money for machine maintenance to reduce downtime? Again, this is also to ensure that patients receive the care they need and improve patient outcomes.
To respond to that.
I mean, yes, Lamaka, I think that when we look at
Thank you, Amaka.
the money that the government spent to send patients outside, it's billions of dollars. I can give many examples here. And this is when we talk to the ministers of health, the minister of finance in these countries, it's an eye-opener. I think here technology is cheap. I mean, relatively, you put it in the context of what is bringing back. Definitely shouldn't be abused, but with the fair market, I would say, standards, in these countries, it's very cheap. It comes back to be very cheap on the long run.
Yeah, and I think you get back to the economics, as I said, okay, big machine, even with on cost, £2 million, treats 700 patients a year, £400 a patient. Immunotherapy, we're talking how much? So yes. Sorry, I'm just behind. I'll come to you there. Just you've been very patiently. The lady here. Yeah. Sorry, you've been very patient.
No,
sorry.
it's fine. It would be from a practical point of view. I'm a head of operations at Amethyst, but I have a long experience of being a clinical nurse specialist in neuro-oncology. So I know Andy Tudor. Hello. The question is, I appreciate the AI technology and, the access to data. But what I'm heavily biased is that all of these innovations get to our end users, which is the patient. So my question would be for Claire. How do you, because it's the care for patients and radiotherapy, it's so multidisciplinary, we have key players from every MDT players. How do you effectively bridge the differences across these MDT players so that our patients get the care in a sensible time that they need to?
Who wants to respond there? Claire.
So you're sort of talking about when a patient is coming for radiotherapy, how do you get them onto radiotherapy? You're talking about maybe a competitiveness within the consultant MDT around what the right pathway is for patients.
Yeah. From all the information that we had today, because you were talking about operations and seamless workflow, and that was fantastic. What I want to get away from this is that all these innovations is driven towards the end, end users, which are our patient, so that we give them the treatment at a timely manner.
So there's definitely competition in MDT around, that's what they're for. To discuss patients. I think this is when you need to introduce the genomics, all of the information that's patient-specific into that group. There does need to be, I guess, the appropriate environment and atmosphere in MDT, but to enable our clinical oncologists to be able to advocate appropriately, they need to have the right technology available for them. So if they want to offer patients certain type of stereotactic treatment, they're not going to win that argument or to get their case agreed if they haven't got the right equipment or if they have to send the patient somewhere else to have that done. So I think the key is we need to actually support our oncologists. Sorry. We need to support our oncologists in those meetings with the equipment that they need, the technology they need, the demonstrated outcomes that they need to be able to take forward to advocate for the patients and radiotherapy for patients in that space. And then we also need to give them the operational flow through to deliver that very, very effectively. So I think ultimately the MDT space is very protected. And it's there for a very good reason to ensure the patient gets the right treatment. But in the radiotherapy sector, we need to make sure that we are there standing ready to deliver that directly to that patient.
And for a vision for the future, I'm thinking with your AI is going to be with us, Lawrence, in 5 years' time. So is in another 6 years' time, we're going to be at the MDT. We're going to have our plans with various technologies and using it and our control probabilities and outcomes, and we can choose. Wouldn't that be lovely? We have the technology. We could do it.
We can do it today. So, we can do seamless treatment, C-plan treat in a day right now if we want to.
Perhaps we should be more ambitious. Perhaps we're just thinking it's
I think the ambition is there. I just think we need to start looking inwardly and thinking about how we are delivering that care, and thinking how can we improve what we're doing. We've got wonderful equipment and technology. We've got very, very dedicated staff. And sometimes it's sort of taking that status quo and saying, well, does a patient need to wait 10 days for a radiotherapy stereotactic fraction?
Perhaps we need a Steve Jobs moment. Perhaps the Apple people should be here saying we're doing this. Questions here. Sorry, there was a gentleman here. You had your hand up before. Sorry. And I'll come bring you in. Oh, sorry. No, you used to, and then back. Sorry.
Okay. Thank you very much. It was really interesting hearing from. Is it Amaka on the screen?
Amaka, you there?
Basically, we've had countries like Uganda and Nigeria using peer pressure group to create this awareness among governmental institutions, to make sure that they increase the access to radiotherapy in these countries. I'm speaking from a country point of view, like Liberia, where there's absolutely no radiotherapy point of view, like zero radiotherapy at all. I did a presentation to the medical student in this country. And this country are deliberately omitting oncology and radiotherapy, like cancer-related issue, because of they are looking at priorities, really. You're looking at malaria and other, obviously, prevalent illnesses, but trying to explain to them the importance of radiotherapy and the impact of cancer on the country. So I just wanted to understand a bit of guidance, really, how you can put these pressures on this government, really, to make them understand the significance and the importance of radiotherapy as well, so that they can consider cancer care as a priority.
Yeah.
Yes, and it's very difficult, and one's aware that I think Liberia's income level is really sort of quite low at the moment, and the government spending is low, but also the health share of the budget is low. So that is a political choice. That I think that you do see some low-income countries in Africa that their leaders have chosen health as something to really deliver to the population. Rwanda is a very good example of that. And I think in Liberia you have had former presidents like President Johnson Sirleaf, who's very interested in these issues, and she's very active on the international stage. So I think to work with civil society and present and former politicians to put pressure on the Ministry of Finance to increase the domestic financing, I feel for you. I mean, I've worked in Liberia. I know how difficult it is, but I think use the examples of countries like Rwanda where health has become a top priority for the head of government, and that's the way to build up the benefit package so that everyone gets the services they need.
Excellent advice, thank you, and we're sorry about that. We're out of time.
Can I just add that?
Sorry, Amika, I think we're out of time, are we? Yes. So sorry. Well, look, let's not stop this conversation here. I want to say firstly, thank you for the panel. That is fantastic. Very good. And I'm sorry we didn't get to everybody. We could have covered radiotherapy in emergencies, and I'll send you to the Global Coalition Radiotherapy website about that. That's another big area. I was going to attack Jackie at the back there and ask her what about managed service deliveries and other questions here. But let's carry on this conversation. I thought it was a fantastic, fantastic session. So just to wrap it up, honestly, thank you. It was great. This was great. We also, Tim Probert's here. We're going to do this radiotherapy essential standard so that perhaps people with cancer plans can then say, this is the next level down, this is what you need for your radiotherapy, and do this there. Obviously, I think Tim's looking for some industry support or whatever, but that would be nice. I think obviously good for the Radiotherapy Awareness Day. We really need a Radiotherapy Awareness Day. We absolutely need this. And also, we want to hear from you. You want to hear back from you. We've got a survey, is that right, Darian? Yeah, if we go through the slides. Oh. Oh, QR code for this. Oh, thank you for our sponsors, everybody. Thank you, thank you, thank you, thank you. You're not just funders, you're actually partners, and serious partners, because, you know, we work together on this. And then this is a QR code for your survey. We've got the QR code. I'm getting good at this. I like it. Please, and let's not stop the conversation now, because we can continue it. And remember, we can do some webinars, we can get through this. And then also, I would say, reaching out to people with questions from lower and middle income countries for advice. These experts are here, we can feed them through. So thank you, everybody. Absolutely fantastic. Thank you, our panel.